All right, we'll go ahead and begin video 2 for our opioids, and we're going to talk about how do they act. Well, again, they're agonal medication. They're going to just agonize, stop the pain. And how does that happen? Binds to opioid pain receptors that we kind of have mentioned a couple times in the brain, and it causes an analgesic response, meaning they're going to be hopefully pain-free, or at least it's going to lessen it. A partial agonist, also called antagonist, because what it is, it's a mixed agonist. It binds to a pain receptor but causes a weaker neurological response than a full agonist because it's got partial antagonist properties, which is going to antagonize that action. And then an antagonist is going to be the opposite of an agonist. It binds to a pain receptor but does not reduce pain signals. And so you're probably thinking, well, why do we have to have an antagonist at all? Why don't we just have agonal medications? After all, right, we need the pain medication to work. Well, the reason why we have to have antagonist medications is much like an antidote. If we need to stop a pain medicine, if we need to stop somebody who's overdosed, if we need to stop, we've overdosed the patient accidentally, we have to have antagonist medications. And then our endorphins, I think I've already covered. They're endogenous, meaning inside the body. Exogenous is outside of the body. Natural bodily mechanism of pain control. They are like our endogenous morphine, or endogenous opiates. Okay, indications for medications like these are agonal medications. They're going to alleviate moderate to severe pain. They're used in common with anesthetics during surgery. So we're giving some high-powered anesthesia, but we're also going to give analgesia just to calm the nervous system down, especially if they're cutting somebody open. Some of the more common ones that we use with anesthetics are fentanyl, sufentanil, alfentanil. As you can see, it's almost all the same family, referred to balanced anesthesia, so it's a combination of drugs. And then here we have our opioids. Morphine, meperidine, which is Demerol, hydromorphone is Dilaudid. So you've got morphine, Demerol, and Dilaudid are all available in injectable forms and used postoperatively also. And then oxycodone is always oral. Oxycontin is a sustained release form of oxycodone that is designed to last up to 12 hours. Oxycodone, for whatever reason, is abused more than oxymorphone. Oxymorphone is a stronger med than oxycodone. And then the cotton, what I wanted to talk about the cotton, C-O-N-T-I-N, see how it's almost the word continue? The cotton in the product name stands for continuous release. So it's going to be a longer sustained release whenever you see the words cotton on it, whether it's oxy, or that we have other words too. And that's why it's saying that it's a sustained release form of oxycodone, oxycontin, and it's designed to last up to 12 hours. Now you're probably thinking, well, why would we ever need to do that? Well, we have cancer, people with cancer pain. And here we have MS cotton. That would be morphine sulfate, long-acting morphine to provide 12 hours of pain relief. It's not just morphine, it's got that continual dose element to it, or chemical makeup, release time, the way it's dissolved. Meperidine, Demerol, available in immediate release dosage forms, both oral and injectable. Morphine does not come in the continuous. Analgesic effects for immediate release drugs usually last for about 4 hours, and that's it, if you're lucky. Sometimes 3 to 4 hours. Breakthrough pain is when one of the long-lasting 12-hour drugs does not provide pain relief for the 12 hours and may be supplemented by immediate release drugs, such as morphine and oxycodone. If we've given them a continuous dose, supposed to last for 12 hours, but just say maybe 6 to 8, a lot of times 9 hours in, they're not quite making that 12 hours. So we call that breakthrough pain because they didn't last the 12 hours, and then the doctor will order something for that breakthrough pain. They've broken through that 12-hour time frame. So now we're looking at some of these a little bit different. Codeine, again, is for mild pain, suppresses the cough center in the medulla, used in many cough suppressants, but it can cause CNS depression because it is classified as an opiate. To avoid this, they usually give dextromethorphan is a non-opioid cough suppressant. Adjuvant analgesic drugs. Remember the word adjuvant? We learned a couple weeks back, or maybe, gosh, almost a month now, I guess. And that's in addition to. Adjuvant means we're going to add something to it. Assist the primary drugs in relieving pain are NSAIDs, non-steroidal anti-inflammatory drugs, which is, ibuprofen and everything umbrellaed under that. Antidepressants, anticonvulsants, corticosteroids. A lot of prednisone we give with to relieve pain, depending on what the pain's for. This allows the use of smaller amounts of opioids, which is really good because we don't want them to be snowed. We want to have something left in case the pain gets greater. And it also helps diminish those adverse effects. Remember, opioids, constipation, nausea and vomiting, and respiratory depression is probably the most unsafe of all of those. Urinary retention, too. Contraindications are known drug allergies, severe asthma. Why severe asthma? A lot of breathing problems. We just said that they cause respiratory depression, so that would be why. Elevated intracranial pressure, morbid obesity, sleep apnea, because sometimes those people can be depressed with the respiratory center much quicker than maybe you or I can. Myasthenia gravis, that's a paralyzing disease of the muscles, and so we don't want to give credence to stopping their lung function. A paralytic ileus, it's already, that's like a paralyzed colon where it's not working. Well, we don't want to slow down the peristalsis anymore. And then pregnancy, of course, we don't want to use it for pregnancy. We don't want to sedate the baby. We need to use another group of drugs. Adverse effects. So what can happen that's not so good with opioids? Psychologic dependence, also known as addiction. American Pain Society, American Society of Addiction, Medicine and American Academy of Pain Medicine in 2006, and that's the last time they've actually looked at all of this, defined this as a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. So there's a lot of work that's gone into addiction. We could talk about just addiction alone for 8 hours, but you can see all of these people have worked together to come up with a definition that really encompasses a lot of stuff. Neurobiologic, what's different with their nervous system than the rest of ours. Genetic, psychosocial, what's going on in the group that they hang out with socially and psychologically. How do they think about drugs? And then environment, where did they grow up? Did they even stand a chance? Physical dependence is a state of physical adaptation that is manifested by a drug class specific withdrawal syndrome that can be produced by abrupt cessation or stopping of the drug, rapid dose reduction, decreasing the blood level of the drug, and or administration of an antagonist. Remember, we said the antagonist will antagonize the effect. Withdrawal symptoms, if somebody is physically dependent, rebound pain, mental agitation, tachycardia, elevated blood pressure, and seizures. And it can be life-threatening. So we have to be very, very careful with people who are physically dependent, especially the poor folks in the ER that come through and something else is going on, that we don't just stop whatever drug that they are on. We've got to figure out a way to wean them off or give them some drug from a different class so that we can help them with for whatever reason they're there. Or we're going to be looking at tachycardia and possibly them seizing. Co-administration of opioids, all of these listed here can cause respiratory depression when administered with an opioid. Alcohol, big one. Antihistamine, you know how groggy antihistamines are in a lot of sleeping medication, or people take them on boats, but they cause you to be really sleepy. So if you're taking a lot of those with opioids, you can have a problem. We all know with alcohol, it depresses the central nervous system. So a lot of people, a lot of our Hollywood stars that they find dead have done this. They've been at parties and had several drinks, and then they go home and they take their benzodiazepines. Those are our sleeping pills. And then they find them dead. Phenothiazine, it's our antipsychotic and tranquilizing drugs, such as compazine, thorazine. They have sedative properties. Prolixin is another one of those. Benzodiazepines are anti-anxiety, are Valium, Xanax, Ativans, Halcyons. Okay, now let's just look at some of the drug profiles. Morphine sulfate is a natural alkaloid derived from the opium poppy. So it's from a plant. It's the drug prototype for all opioids and narcotics. It's a Schedule II controlled substance. Codeine sulfate is a natural opiate alkaloid, more of an antitussive than analgesic. And again, antitussive is cough. Analgesic is for pain. Used by itself, it's classified as a Schedule II, highly addictive. If it's used with Tylenol, they say it's a Schedule III because it's used for mild pain. And it's called Tylenol number 3 to moderate pain and cough. Because we've got codeine and Tylenol together. That's why it's called Tylenol number 3. As long as I'm talking about schedules, let's talk about them real quick. Schedule 1 means no current accepted medical use in the United States. It's a lack of accepted safety for use under medical supervision. I think I already went over this with you, such as heroin, LSD. Schedule 2 is high potential for abuse. So you can see morphine high is a Schedule 2. And Schedule 3 is a combination of products containing less than 15 milligrams of hydrocodone. It usually has, like Vicodin, Tylenol with codeine, usually has Tylenol in it. And Schedule 4 is low potential for abuse, such as Xanax, Valium, Ativan, Versed. Although I've seen a lot of people, I don't even know why they say that, I've seen a lot of people addicted to Valium and Ativan. Okay, we'll stop here and I will start with fentanyl on our video 3.